Welcome to Boom, where we have
Biomechanics on our minds.
Boom.
Boom.
Boom, boom, boom,
Boom, boom, boom, boom.
boom.
Today we have a special episode with two guests. So we are talking with Dr. Hamid Charkhkar, a research assistant professor in the Department of Biomedical Engineering at Case Western Reserve University in Cleveland, Ohio, who also holds an investigator position with the Advanced Platform Technology Center at Cleveland VA Medical Center. And we're also talking with Anna Smith, who was a student at Case Western and is now a research assistant in the neuroprosthesis group with Dr. Charkhkar. Thank you both for being with us today.
Thank you for inviting us. This is exciting. You can call me Hamid.
Yeah, I'm really excited.
Okay, great.
I'm super excited to
Okay.
talk with you guys.
Yeah, we're really excited to have you with us. Anna reached out to us about the podcast, and we've connected and learned more about their research group and all the amazing things they're doing. So we're super excited to be able to have this conversation now.
Yeah, and we've had episodes with students and episodes with professors, but never one together. So it's the first of its kind Boom episode. So we'll start as we do all Boom episodes. When did you first know you wanted to be a biomechanist? And you can each share your story. Let's start with Anna, and then we'll go to her.
Okay, yeah. So I've been fascinated by human movement for pretty much my whole life. I think part of that is I was an athlete and a student athlete. So I was a swimmer up until last year when I graduated. And I think that really got me interested in how the body moves. And I started to look at the body as kind of like the most intricate puzzle of the world, and just how it can move together, and you can see the different systems interact with one another.
Cool. I love, hearing the personal motivation and being able to integrate what you're learning with how you actually behave or feel.
Yeah, definitely. And swimming too. There's a lot that goes on in swimming, and it's a tough sport. So it's cool to think about that from a biomechanics perspective, and all the cool new, I think, swimming biomechanics studies going on with new underwater cameras and stuff too are really fascinating. So yeah, it's a cool start to your story. How about you, Hamid?
So full disclosure, I'm not actually a biomechanist. So I am a electrical engineering by training, but I would like to consider myself a student in biomechanics. And I started as a double E and learned a lot about the circuits and how electrical currents and voltage, can do different things, the rule governing on electrical circuits. And then I was like, well, this is kind of getting too theoretical. Can I apply somehow some of these to human body? And that's how I discovered neuroengineering, which is basically, how electrical signals communicate within our body. And from that, I learned how these electrical signals can determine how we move. And that's how it gets connected to biomechanics. And since then, I've been learning a lot. That is something that I would like to share with your audience, that as someone who doesn't have a formal background in biomechanics, you can still learn a lot. And the goal here these days is to participate in multidisciplinary research, which in our team, we do have people with background in kinesiology, with electrical engineering, and even physical therapy, and mechanical engineering, and all of us sit around a table and discuss ideas. And sometimes I'm just fascinating. I was like, oh, I did not know that. And they say, well, that is pretty basic in biomechanics. I was like, okay, I'm glad you told me that.
It helps when people point those things out, though, because I think I also came from a non-engineering background into bioengineering, biomechanics. I came from a biochemistry, more basic biology background, and it was hard to know when is this something like everybody just learned fundamentally, or is this something I missed in the textbook? Like, so I think that's nice when people do kind of point those things out, even if it feels like, oh, well, I guess it's a fundamental thing.
Exactly. That's one of the things that actually I've learned how to learn to talk the language that everyone that doesn't share my background can understand. Because
Mm.
as I said, in our group, we have people that don't have any engineering background. They're coming from clinical background, and sometimes we who are more accustomed to science and engineering jargon throw out acronyms, and they say, "Wait,
Mm.
what? What is that?" And we have to explain that. And I remember one time, we were discussing developing a graphical user interface in MATLAB, and we were saying, "Oh yeah, let's develop that GUI. Let's develop that GUI." And then someone said, "What is this a sticky thing that you're talking about?" I was like, "Actually, it's not a sticky thing. It's an acronym." And then we explained it to her.
Yeah, yeah, that's so funny. Well, let's fast forward a little bit from that interest and starting to transition into neuroprosthesis to what you're currently doing in your lab. And Hamid, could you share a little bit more about the different projects going on in your lab now? And then maybe you could elaborate more on what your role looks like in respect to those projects. And then Anna can speak a little bit more about what it's like from her perspective working on those projects.
Sure. The lab, we call our lab Restoring Lower Limb Neural Connection. And
Mm,
we're mainly focused on when someone loses a limb or they have some sort of a, neuromuscular disorder that affects lower
mm-hmm,
limb. Uh,
mm-hmm,
what happens to that sensory input? What happens to the neural connection that used to be there while we are walking, while we are maintaining our balance? And now it's gone. Either the limb got amputated and that pathway got disrupted, or
mm,
some sort of underlying condition causes that communication gets weakened or it's not there. So we are pretty much focusing on that neural connection in the lower limb,
mm,
specifically on the sensory aspects of it. And it's something that we take for granted because, for example, when we are walking every day, right? Right now, we are sitting in our chairs and we don't really think about what we feel through our feet unless something goes
mm,
wrong, unless there is a bug on your feet and you immediately notice it. Otherwise, you don't pay that much attention. So, a lot of processes happening in the background, in the subconscious
mm-hmm,
level, and that circuitry is so well developed to alarm us to do its job during locomotion, during maintaining balance, and also to alarm us when something goes wrong, when you come across an obstacle, when you recover from slips and trips, right? And your body knows how to deal with that without you thinking so much, oh, am I supposed to put my foot forward? Am I supposed to adjust my
mm,
hip? These all happening through a lot of elaborate reflex pathways in our body. And
mm-hmm.
we take that for granted. One of the common examples I
Yeah.
often share with the students is that if you have a uh, mm, baby brother or sister, and they have Lego pieces on the floor, and if you step on them, you immediately notice, you immediately withdraw your leg, and while the other leg extends, so your balance could be
Mm-hmm,
maintained, you don't fall down. And the amazing
mm-hmm,
part about it is that the first thing comes to your mind is not how I should coordinate this movement. The first thing is that you get angry at your sibling and said, "Who put this on the floor?" And this circuitry is working all the time, helping us to maintain that balance, to maintain the gait patterns that allow us to navigate different terrains. And
Mm-hmm.
we take it for granted. Obviously, when someone
Yeah,
loses a
yeah.
limb, they receive a prosthesis, right? But that prosthesis is not connected to the human body. I mean, if you think about it, we have made great advances in electronics. We have cell phones that pretty much do everything, and we know great deal about biology. We have mRNA vaccines. We know about the genome and all that. But when it comes to interfacing electronics, robots, and human body, you still see interfaces that are not that much advanced. Look at the glasses we wear, right? The design of the glass hasn't
Mm,
changed over decades. And that's one
mm-hmm.
of the examples of how these assistive devices have not changed, at least the way they interface with the body, over years. The same goes for
Yeah.
prostheses, that we have these prostheses. Even the newer generations have motors, have sensors, but the way they connect to the body still goes through the socket, a majority of them, and it's not really connects to the remaining physiological systems, including the nervous system. And that's the
Right.
system that pretty much controls how we move and receives input from the environment. And that movement can be controlled based on that input. So that's what we work on in the lab, basically
Mm,
developing technology, developing assistive devices, specifically for the lower limb that connects to the nervous system.
mm. Yeah, it's interesting as you were saying that. It just reminded me of something that happened this morning, which is I was on a run and I'm just kind of thinking about other things, and then next thing I know, I step on the branch or like a tree root and I'm rolling my ankle, and yeah, I'm just like, who put that root there? But also the things that my body does in response to that, well, my brain is just thinking, oh no, but my body is like doing all of these things to then protect from it. I only feel this like stretch or that's happening, but I could imagine that if you aren't having those those sensations or feelings to be able to then compensate or have that reflex, that could lead to a lot of challenges with
Exactly,
falls and
exactly.
other things like that. So yeah, it's really amazing to hear that you are working on that in such a complex problem that I'm sure, as you're saying too, you have researchers from all different fields and really requires such a multidisciplinary look on that. Um, yeah, we'd be really interested to learn maybe in more detail. Anna, you can share what you're working on in particular, any particular techniques or methods that your lab is working on to start to um, get at some of these challenges.
Yeah, so I don't necessarily work on the development side. So I'm
Mm-hmm.
interested in physical therapy, in just that, the
Mm,
human movement. So I actually work with our physical therapist as well as our engineers. And
okay.
I'm working on developing an experiment that utilizes a relatively new instrument to us, which is an instrumented staircase. So we can get more information about forces while they're climbing the stairs. And one thing I'm learning is that gait in stairs is not an easy task to look at. There's a lot of factors,
Mm,
and one of the biggest factors being safety. Um,
mm,
and making sure that we don't do anything that's dangerous. Also, there's fatigue that's a huge problem. And one of the things that I'm most interested as I'm investigating this, because I'm really looking at, we've been able to provide sensation. So they can feel to a certain extent the bottom of their foot, but I'm looking at what does that really provide them? So, yes, they can feel something, but what does that mean as far as their functional movements? Are they changing? Are they learning? So, I'm really looking at the motor learning over time, and you know there's going to be an initial change. They're going to feel something and they're going to like
mm-hmm.
start adapting to that. So the more they use the device, there might be subtle changes in how they perform certain tasks.
Mm. Are these mostly people who have had an accident and lost a limb? Like they might have had sort of the proprioception before and have a like understanding of what that would feel like? Or are these also people who were maybe born without a limb or had to have it amputated at a very young age, where this is all sort of new to them? And does that impact their experience with starting with a device like this?
Yeah, so you can correct me if I'm wrong, Hamid, but I am pretty sure that all of our subjects were traumatic, or not even necessarily traumatic. I think there might be one or two diabetes. But
Mm.
especially working with the Veterans Hospital, we focus on veterans. So largely our project is people that might have lost a limb because of active duty or things like that. But
Hmm.
yeah, so no, or they know what it used to feel like.
Yeah,
Hmm.
Anna's correct. Most of our subjects are traumatic amputees, meaning that they lost their limb in a motorcycle accident or due to blast injury. Actually, the first participant in our study is a gentleman who lost his limb in Vietnam War many years ago. And when we implanted him with the technology we have and turned on the system, he was like, wow, I can feel my foot, I can feel my toes
Wow.
after so
Mm.
many years. So it is a very rewarding experience. But you touched on a very important subject that some people lose their limb due to trauma, but one of the conditions that affect lower limb and as a result they cannot feel their limb is diabetes. And
Hmm.
diabetes affecting a lot of people, unfortunately, despite preventative measures, is still growing. A lot of people, um, get diagnosed with this condition and the condition gets worse through time. Is that because of the regulation with the insulin and what happens to the blood flow in the lower limb, um, the nerves that are most sensitive organs in the periphery,
Mhm.
they get affected and they cannot feel their leg. It's called insensate foot. And as a result, they put too much pressure in their foot. And also, there is some inflammation and poor blood supply to the tissue, and they often have ulcers. And these ulcers don't heal up, and eventually they have to lose the limb and they become amputated. So, when you think about the sensory in the periphery, especially in the lower limb, one big aspect is people who lose the limb, but there are other conditions, peripheral vascular disease, diabetes, that
Mm.
the clinical manifestation are actually sensory. People go to doctors
Right.
and say, "Hey, doctor, I mean, I cannot feel my foot, or it's always a
Mm.
tingling in my foot, or if you have grandparents, you might have heard that my feet are killing me, right? So this is a sensory manifestation that shows
Mm.
something else is going on. And that's the way our body let us know that, hey, it's a poor blood circulation. The nerves are, pinched, or do something, because this is going to lead to more major consequences. And that's one of the areas that we are working as well, that it's good to get to people who got amputated, but also can we listen to these sensory cues and maybe
Mhm.
develop a technology that can help people before they lose their limb.
Hmm.
Mhm. Yeah, that's huge. And I think where a lot of healthcare and health research is moving, right? How do we prevent some of these things? How do we act earlier? How do we diagnose earlier? How do we do things earlier? So amazing that you are all thinking that way too, not just post, but before. And I'm wondering, like Anna, you touched on this earlier with talking about the different populations and talking about even some of the challenges of doing this human-centered work. Things are dangerous, like how do you do these studies on a thoughtful way? So it's clear you're working with participants to develop these devices. Do you have tips or best practices on how you gather feedback from members of the community, either during your studies or outside your studies? And then how do you actually translate that feedback into what you're developing? Anna, you can take a stab at that and then feel free to pass it on.
Yeah, so I mean, the primary way that we're talking and getting feedback from users is our own users and asking them questions, and also sometimes not asking them questions. So
Yeah.
I've learned that silence can be very helpful. So sometimes if you don't say anything and you kind of probe them for a little bit and then you give them space in different ways to let you know what's going on, where their head's at, we can actually learn a lot that way as well. And we can learn from, as we're looking at the human movement and what does that tell us about their subconscious responses. Um, so yeah, I would say there's a lot of different ways to tackle getting feedback from users, but I definitely think there's a lot to be said for giving them space and just being open to the conversation. So putting yourself in
Yeah.
front of the audience you're trying to help and hearing them out.
Yeah. Can you think of any specific times, or are there any examples of times that you were really surprised by the feedback that you got from someone that you might not have otherwise expected or considered, but it has had an impact on your work in some way?
Uh, it's hard for me to say. I have been able
Hmm.
to experience meeting our subjects and spending time with them, but I will also say
Hmm.
that we only get to meet them about once a month. So
Mm.
I have a couple experiences, but not a lot. Um, I would say I'm very surprised with how open they are. I think
Mm.
that, at least personally, when I go through something traumatic like losing a limb, I'm very like I could not imagine myself wanting to like put that out there and be like, this is my experience, this is how I'm feeling.
Mm.
Uh, but they're very willing to do that, even with a student they just met, and things like that.
I
Yeah.
I can add to that because actually, as I said, coming from a pure engineering background, I did not have any clinical experience. And
Mm.
during my PhD, I did a lot of rodent work, basically doing different electrode designs for brain-computer interface, measuring neural activity of the brain, but this was done mainly in rats. And then for postdoc, I decided to move to clinical work because I said, I want to see the impact of the research. I just don't want to
Mm.
do work with animals. And so I joined the team in Cleveland, and the lab was based in a medical center in a hospital. So one of the things that my supervisor told me from the get-go is go and attend amputee clinics. So it's basically a clinic that there is a PM&R doctor, physical medicine and rehab doctor, and prosthetist, PTs sit there once a week, and then they visit patients, right? Amputees come to them, complain about different issues they have. And I went up there and sat there, and from for the first couple sessions, it was kind of awkward for me as an engineer. It's like, what am I doing here? And everything is so slow, and patients come in and they don't talk that much. But after spending few sessions, I realized the value because you get to see things that as an engineer you're not often exposed to, and you
Mm.
get to experience some of the issues that these people have. And that's the key, really, to identify the unmet need, right?
Mm.
We often develop technology as engineers because we think, oh, this is really cool to work on, especially for me, it's just let's add this sensor, let's add this component. But when you talk to the end user, they say, well, this is nice, but it's not what I need really. And that's the experience that you don't get unless you sit down, you develop that patience, and you develop that mental capacity to take it in. And one stakeholder, a big stakeholder, are the end users themselves, but also doctors and prosthetists, people who provide care, are a big part of it, right? If we are developing a new monitoring system, a new prosthesis, but the doctor is not aware of it or they don't acknowledge the importance of it, it's going to sit on the shelf. It's not going to find its way to the end user. So it's very important to engage them. And we are lucky in our team. We have a surgeon, we have a PM&R doctor, we have physical therapist, and sometimes when we discuss ideas, they say, "You want to do what?" And then we explain to them that, okay, this is the experiment we are planning to do. And it's sometimes amazing that the viewpoint they have and the question they ask are a type of question that I had never thought about. And I started thinking, I was like, well, that is a valid question. Why we are doing this and how much we have considered, the comfort of the end user, the safety, all of these things, or if the procedure we're doing is a surgical procedure, how much time we're adding to the time that the patient spends in the OR. These are the things, or if we are increasing the risk of infection, these are the things that the doctor thinks firsthand, but as an engineer, we don't. And that's a very unique experience, and I encourage all the students who are not coming from a clinical background, if they have an opportunity to attend clinics, to interact with physicians, though it might not sound very interesting and it might not sound that they are, using every second of their time, it is very helpful, and eventually it's going to pay off because it's an experience you need to be immersed in, and eventually you're going to come back to those moments and you said, I remember that patient visited the clinic and complained about the same issue. It might not happen immediately, but it's going to happen eventually as you work through developing the technology, as you come back and visit new ideas, said, whoa, this is something we need to go back to the end user, to run focus groups, for example, to talk to these people and see if they even like it. And then we take it from there.
Yeah, that's such a great and important point, I think. And I like your point that starting with talking to the user, it's not the end of your feedback from the user at that point, right? You're not just getting some input and then running with it. It's still this continuous feedback loop and continuously iterating and getting a lot of different perspectives too, and then sort of sifting through and finding the patterns, or because everybody's different too, right? And something that might be a challenge for one person or they might not like, another person might like. So I'm sure it's also this balance of trying to find ways that are fit the needs of so many different people, but can also maybe be adapted on more of a personalized level too. Another thing I'm curious about, I remember at the International Society of Biomechanics a couple years ago, we watched a very cool talk from Hugh Herr, who's at MIT and developing lower limb prosthesis that restored proprioception to the user. And we're curious, I guess, maybe what your research lab, when you're developing these techniques, are you working with other labs that are also working on these same problems, or are you trying different ways to tackle these challenges, or sort of what is the approach when there's multiple labs and research groups sort of trying to tackle the same problems?
That is a very important question, actually, and you're right. There are multiple groups that working on restoring sensation, either proprioception or some sort of somatosensation to the lower limb.
Mm-hmm.
Her at MIT is one of the big groups. They developed a approach called AMI, and it's mainly a surgical approach that provides users with proprioception. But I think the solution to this big problem is not a one solution fits all, right? We
Mm-hmm.
are working on the same problem, but we are coming at it from different angles. And
Mm-hmm.
maybe the ultimate solution would be a combination of the multiple approaches because they had success with restoring proprioception, but their technique is still, there are some questions that how it's going to apply to people who previously lost a limb. I know they had some success with people that are about to undergo amputation, so it works.
Mm-hmm.
Also, how much is the downtime? Because if someone is a regular user of a prosthesis and you say, I'm going to give you sensation, but you have to be off your prosthesis for 2 months, often amputees are very active people. They have jobs, and if you don't you cannot wear your prosthesis, that's going to be a big issue and would
Mm-hmm.
prevent them from taking advantage of the technology because they say, no, I cannot afford being off my prosthesis for too long. Then it doesn't matter how good your technology is. It's just that the burden is so high that they say no.
Right.
And there are other groups, actually, there is a group in Europe at EPFL that they have also peripheral interfaces to the residual limb, and they have shown success. There is a group in Pittsburgh that they have a interface with the spinal cord, so that is also very interesting. We do collaborate with some of these groups. We are very open, actually, and I'm using this platform to say we're very open if anyone's interested in collaboration, either if they're
Mm-hmm.
developing a technology, if they're working on the same problem, or they have worked with the amputee population and they're interested to see how their training techniques or the tools that they have would apply to this specific platform and technology.
Mm-hmm.
And there's also another area, I don't know if you're aware or your audience are aware, it's called osseo-integrated prosthesis. Basically, the same concept that you have for um, implants for tooth. You can have the same
Cool.
concept for prosthesis, right? You can have a rod inserted into remaining bones, and then there is an abutment that comes out of the body, and then prosthesis attaches to that. It's very much like you have the implant and the crown for the tooth. You can have the same thing for the prosthesis. And then, because there is a bone interface, there is something called osseoperception that is not widely known, or at least not carefully examined. So we are also working on that area. It says, again, it's not like that you have an ultimate solution that can fit every amputee or every person getting affected
Yeah.
by the musculoskeletal problems in the lower limb. But some people might benefit from osseointegration. Some people might benefit from AMI. Some people might benefit from our nerve-based approach.
Mm-hmm.
But I don't see a reason why we cannot develop a holistic approach that a lot of these different techniques could be combined together, and we provide the best technology and best care to people who have lost a limb.
Mm-hmm.
And I love that, like, you both have sort of talked about this openness that you need to have to feedback and input from users in order to even begin to think about a holistic approach, right? You need to have that openness first, and then you can start to implement something that's more personalized. And I think that's a huge lesson and takeaway that I'm hearing from all of your experiences and wonderful things that you've shared so far.
Exactly, because it's in academia, the important part is to publish papers, get more grants, and kind of get the promotion, get the tenure. But being in a hospital and interacting with end users also remind you that we are in it for a bigger reason. And
Yeah.
if we cannot do something that benefits the amputee population, benefits the end user, it doesn't really matter how many papers you publish, because if you can change someone's lives, that's the ultimate goal. And that's a good thing being in an interdisciplinary group, because you are constantly reminded that there are things that matter the most, and that we have to kind of keep that in focus all the time.
Wow. I mean, yeah, I love that. And I think that's a good reminder of just grounding us as researchers and scientists and, humans, that we all, I know our audience will appreciate, and that Melissa and I really appreciate. Sort of going off of this openness and some learnings maybe from it, I'm curious, there are probably a lot of students and people that are listening that maybe haven't gotten to do a research experience yet. So Anna, I'm wondering if you could share maybe some learnings you've had from your research experience, maybe ones that you thought you might not be able to get from a classroom, and also just any tips you might have for someone wanting to enter into a research experience themselves.
Yeah, so I guess I'll start with getting involved in research. I found that you just kind of have to insert yourself. So really just ask people, and if they don't respond, they're busy. They have a lot on their minds. You can ask them again. They're not going to be mad, mostly. I won't make any promises for everyone, but all the scientists and researchers I've worked with are super open, and they're really excited and dedicated by what they're doing, or to what they're doing. And they want to talk to you. They want your help. They want to know what you're interested in, and that kind of thing. As far as like what I've learned from this experience and what I've gained, I've learned a lot, and I wouldn't even know where to begin. I could talk like the entire hour about lessons I've learned, but I would say the biggest thing I've learned that I definitely didn't get from a classroom is accepting I don't know as an answer to questions. So sometimes I'm getting it. I'll ask a question, and I'll get, I don't know, as a response. And sometimes I'll even go further. I'll look into the research and I'll see, like, I'm trying to find an answer, what's out there. And the truth is there's just more questions than there are answers. And by that, I mean satisfactory answers. So you really just have to get used to existing in a world where you just can't always have an answer or a right answer. So
Yeah.
I would
Yeah.
I would like to add to that, because this is very important to me, and also in our group we are trying to emphasize on this, that sometimes undergrads or new graduate students enter the group and they feel intimidated. They feel that, oh, there are postdocs in the group. There are senior PhDs that sometimes might not be the nicest people in the lab based on how much progress they're making in their thesis. And there's the PI, and who am I to ask the question, or who am I to propose an idea, right? And really, the big goal is everyone has a voice at the table. If you're an undergrad, if you're a rising sophomore, yes, you don't know a lot of the background, you don't know a lot of the jargons, but you still have a sharp mind and you can think, and that's what matters, right? That's what matters. And you can look at the problem and see some issues or bring up some concerns that we might have dismissed, we might have ignored because we are too close to this problem. And you say, how about we, position this ester in a different way? Or how about we also collect this data? Or how about we ask the subject to prime them somehow before they start the experiment? So, and we can discuss that. I'm not saying all the ideas are like wow and breakthroughs, but some of the ideas are pretty good, and people should not feel intimidated that, well, I don't know much. I am just an undergrad student. I am supposed to do what I'm told. And
Mm,
because that mentality is not going to set you up to be a independent thinker, to be a researcher in the future. You
mm,
just need to be bold, brave enough, and say, hey, if I am part of the team, I would like to participate in the discussions and I would like to get an answer, even if my idea doesn't make sense. And then it's the responsibility of the PI and senior staff members to make time and explain and say, well, yes, you're right, or maybe your idea doesn't make sense because of these reasons. But it's always good to have that discussion and debate, and people don't feel intimidated by that hierarchy that often exists in academia that, oh,
yeah,
I am, my knowledge compared to the person who has a PhD is so
yeah,
inferior that I should not ask a question.
yeah, exactly. I've been reflecting on this with my advisor a bit since the end of grad school, and he mentions how my confidence has, as a scientist, has improved over that time. And when I reflect over why that's the case, it's never because, oh, now I know so many things, I feel so much more confident. It's just that I feel more comfortable not knowing things, realizing that I can learn them or figure them out or ask questions, especially ask questions and talk to other people, and put myself in that vulnerable position where I'm like, I know that you know more and I know little about this topic, and but I want to know more, and just leaning into curiosity versus feeling
Mm,
that discomfort of admitting that you might not know something, or that, yeah, I guess that you just need help understanding it. And I think that's something that once you kind of change that mindset or perspective on that, it really changed everything for
mhm.
me. So thank you for touching on that really important point.
Well, I think I can't believe, I feel like we could talk forever. And I love that you said, like, you could talk for an hour on all your learnings. We could talk to you guys for more than that on all of the interesting things you're doing. But I think we're going to start to kind of wrap up with our last two questions for the interview. And we'll do kind of the same, Anna, and then Hamid can answer. Yeah, the first is, can you tell us about a time when you feel like you failed and what you learned from it?
Yeah, so I have felt like I failed like almost every day. I walk out of the lab. I'm like, what did I do? I what did I do? So I guess what I've started to learn and recognize as I reflect on the fact that I feel like that almost every day is that I really like to dive in head first, and I like to think, I'm going to do this project. I'm going to get it done. I'm going to write this code. No one does that in a day. So research
Mm,
and science is not a daily task. You cannot cross it off your to-do
Mm,
list each day and go home.
yeah.
yes.
So I've really been working on just setting reasonable expectations for myself and
Mm,
being a part of the process and letting it be a process.
mm,
Yeah,
mhm.
love that.
For me, I don't like to call it failure, really. I would like to call it when things don't go according to the plan. And
Good
being
reframing.
being in clinical research, that's, as Anna said, it's almost a daily basis, right? Because
Mm,
you work with humans and there are so many factors involved that you cannot control, and things might go just way different. But
yeah, humans working with humans.
yeah,
It's like
exactly.
double
What can
the
go wrong, huh?
Yeah, the expectation is that it goes wrong.
yeah.
But again, bringing some engineering techniques into it, I do like to do a root cause analysis to understand. We came up with a plan, we came up with an expectation. It's really, again, going back to developing a hypothesis, right? You think that, okay, things are supposed to happen certain way. That is basically a hypothesis, and then things don't go that way, and it turns out that your hypothesis to a certain degree was not right. So it's important to do a root cause analysis to understand why things went wrong. But there are also important factors that I have learned over time to kind of develop a sense of humor about when things go wrong. It's okay, and
Mm-hmm.
that kind of joking about it or laugh about it allows you to take a step back and
Mm-hmm.
reflect better as opposed to stressing yourself or pointing finger and say, oh, you did this thing wrong and this is this person's fault. Um, it's important to have that sense of humor as a team to know it is okay to fail because it's
Mm.
research, right? If it was supposed to succeed all the time, we would not be doing it. Um,
Yeah. Yeah.
yeah, and it is something that I've learned when I was a graduate student, and I still deal with it as a faculty regularly. That accepting failure is hard, and
Yeah.
and that is something that I often remind the students because like Anna, like yourselves, a lot of students who go to grad school are A students, are very sharp, talented students, and during undergrad, they are not trained to deal with failure. They're used to
Mm.
ace their classes,
Mm-hmm.
they were getting top grades, and they come to research and they design an experiment, and boom, uh, they look at the data and it doesn't make sense and they get frustrated. Sometimes they question their decision. They say, am I in the right track? Am I doing the right thing going grad school? So I think it's very important to remind them that failure is part of the learning. You take a
Yeah.
step back and you learn, and it's okay if you didn't get it right the first time. So that training, that learning that it's okay to fail, it is something that I think is missing from the undergrad, at least class environment,
Yeah.
and students getting more involved in research, they get an appreciation for it because that's how the real world looks like.
Yeah. Yeah. It's so true. And I think it also can go back to training even from a much younger age, but also through grad school. It's like we don't get rewarded for trying and failing, right? We get rewarded for things going well, and then you put the value in things going well, and then things don't go well in grad school, and you're like, okay, well, I guess I'm a failure and I shouldn't be doing this because it's not going right. And it can be really tough, but if from a younger age we start to be able to build that resilience and understanding that this doesn't define who you are as a person, and instead it's incredible that you're trying these things, you're getting up when you fall down, and you're learning from it and being even better the next time. I think these are all important things that it would be amazing to implement in school and other places in life before, definitely before grad school.
Exactly.
Yeah, so how can people follow you in your work if they want to learn more about it?
I am on LinkedIn. They can email me. Email is the best way. My email actually Hamid at case.edu. And now that we have Zoom and these virtual platforms, if
Mm-hmm.
someone's interested and they have questions, if time allows, I would be happy to arrange, Zoom conversations and we chat a little bit. If they are in Cleveland area, I would love to invite people to visit the lab actually, and see firsthand what we are doing. But yeah, LinkedIn, email, any sort of follow-up, either via Zoom or in person. I'm open to it.
Awesome. Yeah, I'm from the Akron area in Ohio, so
Oh,
next time I'm home visiting
okay.
family,
Yeah,
I'll
you should
stop
definitely
by.
visit.
Yeah, I also have a LinkedIn page, and I'm happy to respond to anyone that has questions about first getting involved, or even if they just want to rant about the fact that they're not getting responses when they're trying to get involved. I'm happy to hear it. I went through it, and I totally get it.
Yeah, that's so nice to hear. Thank you for offering that because I think sometimes it's
Mhm.
just nice for students to not feel alone in that process
Right.
and to talk to other people who have gone through the same thing and know that it's just, one no or a few no's isn't the
It's
end.
normal.
Yeah,
Yeah.
it's totally normal. And there's still so many opportunities out there. So thank you for sharing that. And as our last question, Anna, maybe you could start first about what you're most excited about for the future of biomechanics.
Yeah, so I'm really excited to see some of the technology get more involved in the clinic. So I'm super excited to see this translation. I think there's a growth of specifically in physical therapy using biomechanics as a tool, particularly with force plates, but I think there's a lot more beyond force plates that's going to start
Mm.
entering the clinic and being a part of clinical practice.
Awesome. Yeah, that's super exciting. How about you, Hamid?
Yeah, I think for me, it's really redefining the concept of disability, right? If someone
Mm.
loses a limb or they have a condition that doesn't allow them to walk or maintain their
Mm-hmm.
balance, they can use assistive technology that is well integrated into their body and really bridging that gap between assistive technology, artificial limb, and natural limb, right? So
Mhm.
if they receive a prosthesis, they don't say, "Well, I have a prosthesis." They say, "No, my actual limb was not working, so I have a limb that works pretty much as well as the natural limb." So that is the goal, and that's what we would
Mm.
like to get to. And if that happens, then um, really we are changing that concept, who is disabled versus who is
Mm.
not,
Yeah.
and they should not feel that they're restricted in what they can do and what limits they can push based on that disability. And I'm very excited because there's been so many technological advances. As you mentioned, there are multiple groups that
Mm-hmm.
now are working in this specific area. There are
Mm-hmm.
new uh, breaking news coming out of the contribution of the sensory and how we can augment
Mhm.
the sensation through the lower limb. And hopefully that translates, and a lot of people can benefit from the outcomes of this technology.
Mm-hmm.
Mhm. Yes, completely. You should. We That reminds us of our mobility series, which we did, I think, last year at this time.
Yeah.
Um, and also the book by Sarah Hendren, who's also featured in our series, and it's called "What Can a Body Do?" and it's all about this idea of, we only have disability because we have such a rigid, inflexible built world. But if we
Exactly.
can redefine that, yeah. So I love that. I love to hear that. We love to hear that.
Mm-hmm.
Um, and we love that you guys are living that, living and breathing that in the work that you do every day. So thank you so much for sharing that with us, and keep doing the amazing, impactful work that you're doing.
Thanks for
Yeah,
inviting
thank you
us.
so much. Yeah. Yeah, yeah. Thank you for being on. It's been an awesome conversation. We're really grateful for you taking the time to do that, and we can't wait for our listeners to learn from you.
Yeah, happy to
Yeah.
share.
Biomechanics off our minds.